Okay, so here we are going to talk about the different respiratory acid-base imbalances that we might see. So first of all, respiratory acidosis. This is caused by an excess of dissolved carbon dioxide or carbonic acid. So it's characterized by a pH less than 7.35 and a PaCO2 greater than 45. We know it can be either acute or chronic. In chronic respiratory acidosis, the bicarbonate is higher than 26 as well, as the kidneys compensate by retaining bicarbonate. So in chronic respiratory acidosis, you're going to see that compensatory bicarbonate renal action trying to keep us in our normal pH range. So acute respiratory acidosis, it occurs due to a sudden failure of ventilation. This could be from chest trauma, maybe aspiration of a foreign body, acute pneumonia, and it could be from overdoses of a narcotic or a sedative medication that leads to depressed respirations. Because acute respiratory acidosis occurs with the sudden onset of hypoventilation, for example with cardiac arrest, the PaCO2 rises rapidly and the pH falls markedly. So a pH of 7 or lower can actually occur within minutes, which is going to result in death if it's not corrected. Initially, the serum bicarbonate level is unchanged because the compensatory response of the kidneys occurs over hours to days. So our respiratory changes can occur very suddenly, very quickly. It takes the renal system hours to days to try to compensate. So chronic respiratory acidosis is associated with chronic respiratory or neuromuscular conditions such as COPD, asthma, cystic fibrosis, and multiple sclerosis. The conditions affect alveolar ventilation because of airway obstruction or structural changes in the lung and limited chest wall expansion. Most patients with chronic respiratory acidosis have COPD. In chronic respiratory acidosis, the PaCO2 increases over time and it remains elevated. The kidneys do retain bicarbonate, which increases the bicarbonate levels, and the pH often remains close to the normal range because of this adequate metabolic compensation. If you look at this slide, at the tips of the white arrows, you can see an outline. So what this X-ray is showing is actually a collapsed lung. So all that, all the black space kind of out to the right side of that line, that's inside the chest wall cavity, and that's area that should be filled with lung, but that lung, it looks like it's about halfway collapsed. So when we're doing an assessment for respiratory acidosis, hypercapnia, which is increased carbon dioxide levels, it affects the neurological function and the cardiovascular system. Carbon dioxide does rapidly cross the blood-brain barrier, which causes cerebral blood vessels to dilate, and if this condition continues, we're going to see an increase in intracranial pressure. Peripheral vasodilation also occurs, and our pulse rate increases. We become tachycardic to try to maintain cardiac output. So we might have an acute headache, get warm, flushed skin, you'll see that elevated pulse, people might get blurred vision, irritability, altered mental status, eventually a decreased level of consciousness, and you can see cardiac arrest. If the carbon dioxide levels rise more gradually, such as with some of our chronic respiratory disorders, we might not have those acute effects of hypercapnia. And when those carbon dioxide levels are chronically elevated, the respiratory center becomes less sensitive to the gas as a stimulant of the respiratory drive. With our chronic respiratory acidosis, we might see some weakness, people may complain of dull headache, maybe some sleep disturbances with daytime sleepiness, And you can also see impaired memory and in some cases even some personality changes. So our treatment of respiratory acidosis, whether it's acute or chronic, is going to focus on improving alveolar ventilation and gas exchange. Our care involves the efforts of the entire healthcare team. So respiratory therapy might provide breathing treatments and any other related therapies as ordered. As the nurse, you need to frequently assess respiratory status and lung sounds. We want to evaluate mental status. We need to document and report any changes in alertness. We want our client placed either in semi-Fowler's or Fowler's position as tolerated. We are going to encourage them to use pursed lip breathing if it's a client with chronic respiratory acidosis. Of course, we are monitoring airway and ventilation. We may need to insert an artificial airway and prepare for mechanical ventilation as necessary. This will probably be more respiratory therapy, but you may see some additional pulmonary therapy measures, so inhalation therapy, percussion, and postural drainage, along with bronchodilators. We're going to want to monitor fluid intake and output, our vital signs, and we'll probably be doing serial ABGs. And then we need to also be aware that this client with respiratory distress is probably not super comfortable, so we need to give some pain medication or something for comfort as indicated. And then we also want to make sure that they maintain adequate hydration. In some cases, we may actually give bicarbonate via IV because we know it takes that renal system several hours to several days to really compensate for a respiratory problem. So we might need to give them actual bicarb while we wait for their body to produce it. And then atropine we will give if they are severely bradycardic, just to help bring their heart rate up. So respiratory alkalosis, on the other hand, this is characterized by a pH that is greater than 7.45 and a PaCO2 of less than 35. It is pretty much always caused by hyperventilation, which leads to a carbon dioxide deficit because you are breathing all that carbon dioxide out. In acute respiratory alkalosis, the pH rises rapidly as the PaCO2 falls. And then we know the kidneys are unable to adapt rapidly to this change in pH, so our bicarbonate level is going to remain within normal limits. So anxiety-based hyperventilation is the most common cause of an acute respiratory alkalosis. Other physiological causes of hyperventilation can be fever, so high fever, hypoxia, some gram-negative bacteremia. You can have a thyrotoxicosis, which is excessive amounts of thyroid hormones. You can also see it with encephalitis. Some of the high progesterone levels in pregnancy actually directly stimulate the respiratory center, which can also potentially lead to hyperventilation and respiratory alkalosis. We also see it happening during anesthesia or if the person is being mechanically ventilated, if the rate and the depth of the ventilation is excessive. If the hyperventilation continues, the kidneys will eventually compensate by eliminating bicarbonate to restore that bicarbonate to carbonic acid ratio. So alkalosis increases binding of extracellular calcium to albumin, which reduces ionized calcium levels. So as a result of this, we're going to see neuromuscular excitability, and we're going to have manifestations that are similar to hypocalcemia. So these include lightheadedness, a feeling of panic or difficulty concentrating. We can have circumoral and distal extremity paresthesias, so that's that tingling like in your fingers and around your lips. You might see tremors, You might see a positive Schwastik sign, which is a facial spasm if you tap on the facial nerve. And then you could also have Trousseau's sign, which is a spasm of the hand and the forearm. Your patient might experience tinnitus, which is the ringing in the ears, maybe a sensation of chest tightness. They can have palpitations or cardiac dysrhythmias. It's also possible for them to have seizures and a complete loss of consciousness. These low carbon dioxide levels in the blood cause vasoconstriction of cerebral vessels, so it increases the neurological manifestations of this disorder. So management is going to focus on correcting the imbalance and treating the underlying cause. It's important that we create a calm, quiet, low stimulation environment to reduce that patient's anxiety or panic. We also want to make sure that an ABG has been completed prior to administration of medications or oxygen therapy. We might need to give a sedative or an anti-anxiety agent prior to administration of those medications or oxygen therapy as well. You guys have probably seen the person breathing into the paper bag, and the use of paper bags will actually help raise carbon dioxide levels in clients with a true hyperventilation syndrome. But if you are just breathing and rebreathing CO2, what are you not breathing? Oxygen, right? So it can cause pretty profound hypoxia if you're not careful with it. And then elevated carbon dioxide levels have been found to trigger panic attacks, which can also further exacerbate the hyperventilation. So the best treatment for suspected hyperventilation is to teach breathing exercises and encourage the patient to take slow, regular breaths. We're going to want to monitor vital signs, level of consciousness, and ABGs. We're going to encourage the patient to breathe more slowly, teach some breathing and stress reduction techniques. We can administer sedatives or anti-anxiety agents as ordered. If our patient is ventilated, we may need to monitor or adjust the ventilator settings. We're going to give oxygen as ordered, and again, we're going to maintain fluid status.